I thought reassuring. This is Daniel Mullins. Dr. Kwon, I wasn't sure if you wanted to say anything to the group before we get started.
Can you hear me now?
Yes, sounds very good.
I wanted to thank you all for participating, and thank you, Daniel, and your team for putting together this presentation. We're looking forward to Ellen's talk. I just have one brief announcement, or two brief announcements, if I could make that real quickly. One, the ARC Research Conference is returning this fall, and the title of the conference is Producing Evidence and Engaging Partners to Improve Healthcare. And this meeting will be co-hosted with Academy Health. The ARC Research Conference will be taking place October 4th through 6th in Arlington, Virginia, and I'll send these details to each of the R24 principal investigators. And the other announcement I wanted to make is our next PCOR webinar is scheduled for June 25th at 3 p.m. That will be hosted by the Henry Ford Health System R24 site. And again, I'll be sending that information out to all the principal investigators shortly. Thank you very much.
Welcome to all of those who have joined. It looks like we can see who's on the line from kind of in the main room. Some of you have identified by your name and some by your affiliation. So instead of doing a full introduction, I think what we'll do is, as people have questions, ask that you introduce yourself at that point when you have questions. Just to remind you, this webinar today is being brought by the University of Maryland R24. We call ourselves the Patients Program. And in addition to the professional schools at the University of Maryland, we have 5 communities of patients and healthcare providers and 2 research partners. One of those research partners is the Center for Medical Technology Policy, or CMTP, and their role on the Patients Program is really to help us with stakeholder engagement. So today we're delighted that Ellen Tambor, who is our point person from CMTP, is here to present her views on patient versus consumer versus advocate in patient-centered outcomes research. Ellen has quite a bit of experience in stakeholder engagement. She currently manages the PCOR Patient and Consumer Engagement Task Force. She also has done, or kind of has been involved in that in the past, and she also has done quite a bit of work with a variety of PCOR grants funded by AHRQ, PCOR, and others, and really helping researchers understand how to engage individuals, and really has brought to light some of the differences in terms of kind of when is it appropriate to engage a patient versus others, and she's going to share her views today. Next slide. Just want to remind everybody that we are supported by AHRQ, as are the rest of you, under the R24 mechanism, and want to say that the views that Ellen and I expressed today are not those of AHRQ. I'm going to turn it over to Ellen to go through the objectives in her presentation, but I do want to say that we're very interactive, so even before Ellen says it, I want to say, if you have an alternative view or if you have a question, please stop Ellen and don't feel like you need to wait for her to finish her presentation before you jump in with questions. Ellen?
Great, thanks for having me. So the objectives today, and I was glad to hear Daniel say that I was presenting my views, because you know, they are my views, and certainly open for disagreement or discussion. But what we'd like to do is discuss factors to consider in deciding which category or categories of patient representatives to include in PCOR projects. Talk about some examples from CMTP's work of engaging patients in different PCOR contexts, and then I would like to make sure we leave enough time to hear from you folks about experiences you've had and how you've gone about selecting patient representatives for studies. And so I have to admit that when I started working on this, it was very daunting because there's no consistency in terminology. a lot of the differences between the terms you see here, sometimes there's subtle differences in meaning. Sometimes people use the same word to indicate different perspectives. And there's not a lot of documentation. So getting in and teasing apart what all these different categories are, and really how to think through this and identifying patient representatives for any given PCOR project can be a little overwhelming sometimes. So just to point out a few of the areas where it gets a little slippery, distinguishing one from the other. You've probably heard people refer to patient representatives or consumer representatives. If you think about it, technically any patient who receives care is also a consumer of health care. And then patient advocates are often distinguished from patients, but very frequently patient advocates are also patients themselves, or they may be family members of patients. Community is used as another designation, but patient communities are one type of community. And often the perspectives of family members or caregivers are important, sometimes because they are serving as surrogates for a patient who's a child or elderly or cognitively impaired. And sometimes even when the patient can speak for themselves, it's interesting to get the perspective of family and caregivers just because they have a different point of view. But I guess the kind of general point is that all of these perspectives can be really important to making sure that PCOR meets the needs of end users, and that which category or categories should be represented in a particular project is highly context specific. So just to give you an example of how groups define patients differently, the official definition of patients that the Corps uses in talking about this funded work is persons with current or past experience of illness or injury, family members or other unpaid caregivers of patients, or members of advocacy organizations that represent patients and caregivers. So sometimes patient is really used as a shorthand to apply a lot of other different types of perspectives than just patients with the actual experience of a particular disease or condition. But I think the important point here also is that people do use different terminology, that it's important to really be clear when we say a patient representative, defining exactly what we mean by that, I think is helpful. And just to touch on some of the other types of perspectives, consumers. So again, like I said, technically anyone who uses healthcare is a consumer of healthcare. And in the diagram earlier, I included service users and the public. I think those are primarily terms used in the UK. So they a lot of times use the term service users to talk about anyone receiving care from the national health system, or the public to to talk about society as a whole as receiving care from the national health system. The term consumer is sometimes used to be more inclusive, to not just distinguish a group based on having a particular illness, or doesn't denote experience with any particular disease or condition. There's sometimes a financial connotation that if you're a consumer, you're interested in more than just the quality of the care you're receiving. You're interested in the cost or the value of care. And I have heard in a number of situations some patient advocates who object to being called consumers. And the explanation I've been given, and there may be others, is that they feel it may imply a degree of choice that in some context patients may not really have or feel they have. And then just some examples of consumer advocacy organizations that we've worked with. Consumers United for Evidence-Based Healthcare, or CUE, and CUE is a coalition of a lot of different advocacy, patient advocacy and consumer advocacy organizations with the goal of improving consumers' ability to engage in and demand high-quality health care. And then I'm sure you've all heard of consumer reports, and they also have a health and wellness division that's focused on the quality and value of care that is sometimes a useful perspective to include. And then one last point about consumers, I think when we start talking about learning healthcare systems, it becomes a particularly relevant perspective because consumers are, anyone that's included in one of those health systems is a consumer of healthcare provided by that system and has an interest in both keeping the cost of the system down and improving the quality of care that the system is providing. And so community members, another categorization which, as many of you I'm sure know, has a long history in community-based participatory research, where it's defined as those who have a shared unit of, there's a typo, shared unit of identity. And as I mentioned before, patient community is one type of community, but it can also be geography or culture, which is often the focus in CDPR research, is that unit of shared identity. Patient advocate. Another one of those terms that can be used to refer to a lot of different things. It can be either someone who works with individual patients to help them through receiving healthcare services, or organizations that provide that, or it can be groups of patients who work towards other objectives, and advocacy organizations have different goals and priorities that include access to care, fundraising, awareness and education, policy change, and research. So in thinking about advocacy organizations in the context of PCOR, I think it's important to consider what the objectives and focus of a particular advocacy organization is. And oftentimes, improving the quality of research is a very important focus, but not always, and there's slight differences in the focus of these different organizations. And like I mentioned before, to say an advocate doesn't necessarily mean someone who's advocating for patients without having personal experience, because a lot of times, I would say actually more often than not, the advocates I've worked with from organizations started out in that organization because they were drawn by their own personal experience or the experience with someone that they knew. And I also think in deciding about including approaching advocacy organizations to participate in the study as opposed to individual patient representatives, there's both some pluses and minuses. Some of the advantages of partnering with an advocacy organization is that they have access to a large population of patients for certain activities like topic generation and dissemination of findings. They are likely making a point to stay up to date on current treatments and research. And a lot of them also offer scientific training for advocates so that they can participate as research advocates. And there actually are some advocacy organizations focused solely on that. But one that comes to mind is Research Advocacy Network, who's is in the area of oncology, but the whole purpose of that organization is to train people to participate as research advocates. Some possible disadvantages where you might really want to consider a patient representative that's not part of an advocacy organization is that there are some occasions where a representative from our organization may not have personal experience with this disease or condition. Even if they did at one point, they may be out of touch with the day-to-day lives of patients. So they may offer a high-level view as opposed to a more ground-level view of what the day-to-day experience of patients is like. Frequently, minorities and people from lower educational socioeconomic environments are underrepresented. Not always, but frequently. And I think there are some organizations that focus on making sure that gap in representation is filled, but often that's not the case. So I think, we started out calling this talk patients versus consumers versus advocates. And I think it's not always important to separate the perspectives in the categories, but more to think about for any given context or project, what type of experience and knowledge is most important, and then use that to inform decisions about what types of patient representatives to include. And by the way, just on a personal preference, I tend to say patient representatives because I think, to me, it most clearly includes anyone whose role on a project is to represent the concerns of patients. So it could be, consumer, community, but it's all focused on the interest of the patient in that particular situation. So just a personal preference. Speaking about, for any particular project, how to go about deciding which types of perspectives to include, I think it's useful to think through a number of issues. One being the particular topic, which includes the characteristics of the disease or condition, whether it's rare or common, how the severity, age of onset, how acquired, whether there's particular issues associated with the condition, like stigma or health disparities. But then also thinking about the population that's affected and whether it's the age of the population, gender, anything else that distinguishes that particular population that might affect how you go about thinking through the most appropriate representatives. And then it's also important, I think, the stage of research. And again, my personal view and experience, when you're starting out in topic generation, often you really are looking to include as many diverse types of perspectives as possible. And then prioritization, you can also do at a very broad population level or a little more focused approach. Study planning and implementation has increased demands for scientific or research knowledge. You're looking for a smaller number of representatives to participate in sort of detailed work of planning studies and working on protocols. And then when you get to the end stage of translation and dissemination, you want to think more broadly about reaching out again to as broad a group of patients as you can reach. And then other considerations in terms of the goals of the project, whether you're looking for individuals to just provide sort of one-off feedback on materials for a study, whether you're looking for someone to serve on a committee that's going to be continuing on for some period of time, et cetera. A lot of logistical issues that might affect decisions about who to engage.
Ellen, thanks very much. This is Daniel Mullins again. I think before we go to the examples, if anyone has a question, you'll have to tap on the talk button to present your question, or if you prefer, you can enter it as text through the chat. As we said, we'll continue to take questions throughout the presentation. Ellen's got a couple examples that she's going to present, but if you had questions about the general approach that she's suggested so far in deciding between the different types of patient representatives, we can take one or two questions now. Otherwise, she'll continue with some examples from her own work, and then we'll have some questions at the end. But let's go through the first example, Ellen.
Okay, so the first example is in the area of cystic fibrosis, which, starting at the top of the questions, to consider the characteristics of the condition and the population affected by the condition. It's, as I'm sure many of you know, a chronic, rare, hereditary condition. There's a very active advocate community, and there has been for a long time. It's historically been thought of as a pediatric condition, with the parents being the most involved in advocacy efforts, and that was because the lifespan expectations for children with cystic fibrosis were not particularly good at one point in time. So the efforts were from the parents. They were very focused on fundraising, raising awareness, and getting people to participate in clinical trials to find a cure. Fortunately, with all of that investment, there's a lot more available to patients in terms of treatments. Patients with cystic fibrosis are living much longer, many well into later adulthood. And so there's been sort of a shift from this is a condition of children who aren't going to live very long unless we find a cure, to this is more of a chronic condition that people may be living with for many years, and those patients have a lot of interest in research that's going to inform decisions about treatment that are going to affect their quality of life. And the adult CF patients have tended to feel left out of the process a little bit, I believe. And it just brings up another point about, I think, identifying what types of perspectives to include in a particular situation. It often takes some pre-engagement work to learn more about the patient community, to find out what perspectives we need to make sure to include. So just in this specific example, we conducted some key informant interviews and some focus groups with patients and groups of parents to try to identify what are the different types of patient experiences we want to make sure are represented, and to give us guidance on reaching out to a broader group of patient representatives. So for this particular project, the overall long-term goal is to build a infrastructure for ongoing PCOR within the Cystic Fibrosis Foundation. At the stage we're in now, the focus is really on topic generation and prioritization, with the goal of developing a PCOR research agenda that meets the information needs of patients and families. To date, the PER and PCOR that the foundation does fund, the topics are selected by a group of clinicians and researchers, and there haven't historically been. There's lots of patient involvement in the foundation's work in other areas, but there has not been what we consider patient engagement in PCOR so far. So that's what we're focusing on. So we decided that what we needed to do was get together a group of CF patients and family members and make it as diverse a group as possible while still keeping it to a small enough number to be able to really dig in and work together on an ongoing basis. So I think that's actually. So like I said, we started by identifying the range of perspectives we wanted to include through focus groups. We had the foundation distributed an application very widely to its centers. People who applied to be on this particular committee submitted applications, which we went through with the goal of trying to create, we wanted to keep the number limited to 12, but we wanted to include within that 12 as many different types of perspectives as possible. So we balanced half the group is adult patients and half is family members, primarily parents, but we also have a sibling and a spouse participating. We also looked to balance in terms of the age of the adult patients or the age of a child, trying to select people from different parts of the country and try to include a mix of men and women. And in this group, actually, we're having our first, during our first meeting with this group next week. But I think the really important part is we don't expect this group to have all of the answers to what the broad community of CF patients and family members wants and needs. They really are helping us to develop a plan which will include outreach to a broader community of patients. So even though this committee is only 12 people, ultimately they will help provide guidance on outreach education and things like topic solicitation to the broader CF patient family community, and help get information out to the broader community, but also help us to collect information from the community and synthesize that information, and hopefully the end result will be a research agenda that includes as many perspectives as possible. And I could stop there if there's any questions about that particular example. I have a couple more.
Let's go through the final two examples, and then I know we have some questions for them, and I'm sure they'll have some questions for you.
Okay. I'll go through the other two examples fairly quickly, but just to sort of give you a contrast of very different types of PCOR projects requiring different types of perspectives. The second example is the area of uterine fibroids, and this is a PCOR-funded project, and the objective was to utilize existing electronic databases to compare effectiveness of treatments. So in this case, the objectives involving the stakeholders was for them to really partner with the investigators to help refine the study protocol, interpret the results, and frame messages, and assist with dissemination strategies. So in this case, we really, in the cystic fibrosis case, we had no criteria that people needed to have any knowledge of research or to participate. In this case, we really wanted people who would be able to participate in a meaningful way in these discussions, and sometimes it requires providing that when you start with people. In this case, this work built on a previous project funded by ARC to do topic prioritization, and so we had a number of patient advocates from that work who had been very engaged in this work for a long time, and were quite knowledgeable about the issues involving research in this area and the treatment options. And in this case, I think we have several patient advocates working in this stakeholder committee, and I think all of them are patients themselves who have personal experience with uterine fibroids, but also are with leaders within different advocacy organizations. And this is another situation where, looking at the landscape of the advocacy community, there's a lot of different small uterine fibroids advocacy organizations that serve the needs of different subgroups of the population. So we tried to include people from a number of organizations in this study. And like I said, in this case, we really wanted to include people that had sufficient knowledge of treatment alternatives and the available evidence to participate in protocol discussions, which they're quite able to do without any difficulty. And then importantly, as we get into thinking about dissemination strategies, having those advocacy organizations that are in deep connections into the patient community is going to be a really important resource.
You have one final example.
Yeah. Final example, and this one again is quite different. It is the Chicago Area Patient-Centered Outcomes Research Network, which is one of the 11 clinical data research networks that's part of the CoreNet. It's a collaboration of 10 healthcare organizations to establish a sustainable infrastructure for PCOR in Chicago. They were required as part of the application process to identify disease cohorts to focus on, including rare diseases and common. So anemia, sickle cell, asthma, C. difficile, obesity, and diabetes are the disease areas that Capricorn is focusing on, but that's it's not limited to individuals with those conditions or their representatives, because ultimately, as the network grows, the idea is that as many people as possible that receive care from one of the collaborating organizations will consent to have their data included in the network. And so the goal here is it's a long-term project with the goal of engaging patient representatives in all aspects of the work. And so in this case, the Patient and Clinician Advisory Committee is quite diverse and includes patients and parents representing the priority disease areas, and also representatives from several of the advocacy organizations. But then also, there's a much broader focus on community in this case, because the overarching goal is to improve health outcomes for the Chicago community. So there's a geographic community aspect. And so we included people that were not necessarily focused on a particular disease or condition, but could represent the needs of the broader Chicago community. And that includes pastor and community activist, public health administrator, someone representing a community health charities organization, and then a research advocate who is also a community PCOR organizer. And I think, again, in this case, the expectation is not that this group of 11 people will represent every patient or community member, but that they can help us devise strategies for including those perspectives, and also serve as sort of trusted intermediaries with the community. The community members are largely not going to know what the World Capricorn is, but they may know a lot about some of the organizations that are on this committee, and therefore be more willing to engage with the network. So those are 3 examples, and just to wrap up quickly, as I mentioned, there's advantages and disadvantages to including advocates as opposed to sort of, I've yet to come up with a really appropriate term. It's independent patients or patients that are not affiliated with a particular organization. That is really, I think, important in some cases in particular to consider consumer and community perspectives. In deciding what type of representatives to include, context is really, really key. And that there's a lot of different factors related to the topic of the research, the stage, the goals that can inform those decisions.
Great. Well, thanks very much, Ellen. This is Danielle Mullins again. I first wanted to welcome Dr. Tamara Willis. I know you joined a couple of minutes into the call, so I didn't want to interrupt the flow at that time. But we heard from Dr. Harry Kwan at the beginning about the AHRQ conference that's coming up October 4th to 6th, and he mentioned that the next webinar will be presented by Henry Ford. I didn't know, Tamara, if you had anything else that you wanted to bring to the group before we go into general discussion?
No, thanks. Just happy to be on the call.
Thanks for joining us. One thing that I've talked with some of the other leaders of the other R24s about is making these calls more interactive. And so what we've done to get that started is put up some questions that we'd like to hear from the other R24 study teams on the topic that Ellen just presented. So what are your experiences with how you have selected patient representatives for your studies? Have you engaged both advocates as well as patients? And if that was a deliberate decision, why did you make the decision that you did? So does anybody want to start with either of those first 2 questions? And again, remember, I think to speak sense, you'll have to hit the talk button on your screen. There's no way that I can see if you're raising your hand, so I just ask anybody to go ahead and hit the talk button and share your views on either how you have selected patient representatives for your studies, including perhaps the patients who are involved in your R24 infrastructure, or kind of in making decisions about patients versus advocates, how have you decided whether to go with a patient or an advocate? And if for some reason you can't figure out how to get the volume, you can always kind of type a comment or 2 and I can read it. But if you want to give your views, just go ahead and hit the talk button. I think I must have put everybody. I can see that UTMB is on and Missouri is on without a specific name. So either of those 2 groups, I know that both of you have engaged patients. So either UTMB or Missouri, do you want to share any of your experiences?
Hello, this is Tim Reinfetter from UTMB. We engage patients through some local support groups. Wouldn't necessarily call them advocacy groups. They call them more support. They're scattered throughout our region. And we use the term patients, and no one really seems to have to struggle with that. So that's kind of how we've put together our stakeholder groups and selected key members for the stakeholder groups.
Were those support groups that you were already familiar with, or did you have to kind of build a relationship with them in order to find some representatives?
The initial group actually was a support group connected to our hospital system. The additional ones are really connected to other outreach areas. So some of the people we've worked with have then gone on to other areas. So it kind of is more of a network that just naturally has evolved over time. Some by us finding them, probably more us finding them than them finding us.
Any other groups want to share? And I have some follow-up questions, but see if there's any other groups that want to share your experiences with selecting patient representatives or this issue of determining should I use a patient or a family member or an advocate or a consumer?
Hi, this is David Mayer at the University of Missouri. So we started also trying to align with a patient family advisory group at our hospital, which tended to be individual patients who had strong views focused on their own health experiences. And we got some useful feedback out of that group, but as time went on, we decided that we really needed to create a freestanding group, and we are still in the process of convening that, but it's been selecting, so far at least, identifying diverse people that we knew had healthcare experiences either as caregivers or as patients related to chronic illnesses, which is our sort of one of our foci. We've also been engaged in doing, one of our projects involves chronic pain, and we've been doing interviews with chronic pain patients, although we haven't explicitly selected a representative to be part of that study yet. So I guess I have to say that this is all still something of a work in progress for us. We're still learning how to do this.
Yeah, I think both UTMB and Missouri made an issue, which is that when you work with groups that are kind of from a support group or like that sometimes when you bring them in the context of trying to develop research, that the patients will want to tell their disease history and story. And especially if you have limited time, there is this kind of gentle balance between wanting full engagement and having a task at hand, which is we're trying to decide what are the important patient-centered outcomes research questions to study and how do we prioritize. And if a patient goes on too long for kind of telling their story, it doesn't leave enough time. And we've asked some of our patients how to handle that. So we have some patients who serve as advisors at University of Maryland, and one of the suggestions they gave was to ask your patient to write out their story if they want to share it, and then to share a copy of that with everybody who's on the advisory committee, so that people come in with understanding, you know, the experience that the patients bring. And so you're respecting the patient's desire to kind of tell who they are, but not using up, you know, valuable time if you only have an hour or two for a meeting. And so I was wondering, Ellen, if you have anything else to add about this concept of, you know, we want to engage patients, but we want to make sure that we prepare them for why they're coming to us as advisors.
Yeah, and I think especially when you're trying to identify, you know, a small group of patients to serve on an advisory board, you want them to, as much as possible, represent perspectives that are commonly shared and not just their own personal experience, even though obviously their own personal experience is important and informs the way that they view. But one thing we've tended to do, I think it's pretty obvious when you're talking with a patient they tend to think about common concerns in the broader community, or whether they're very focused on what their personal experience is. And I think sometimes that's just a function of how far removed they are from it. And from the cystic fibrosis example, after meeting with some groups of parents, we decided that we weren't going to include any parents who had a child under a certain age, because it was very new to them. They were very sort of overwhelmed by the task of caring for their child, and it was really hard for them to think more broadly about the needs of the community as a whole. And so I think, you know, sometimes just talking, if you're trying to decide whether to include somebody on a committee, that you want to make sure you have someone that's going to be a good fit, that's going to be able to contribute over time, just talking to them, you can usually get a sense of their capacity to really think beyond their own experience.
I think that also lends to some of the advantages that you spoke very nicely about advocates. And yet I think that you point out some of the concerns that people have about advocates. And so I know at the University of Maryland, oftentimes we'll use an advocacy organization to help us identify a patient if we're looking to kind of bring in another patient who is not already in the University of Maryland system. But we do struggle with kind of that balance that you spoke about, is getting the voice of the patient versus an advocate who probably is more knowledgeable about some of the research areas, but then maybe doesn't have that personal experience. I'm wondering if any of them, our R24s, have struggled with this issue of advocates versus patients, and have you worked with advocacy organizations to identify patients? Have you not even thought about this until today, or have you actually included advocates in addition to patients? And what are your experiences in the other R24s?
I mean, we don't necessarily use the term advocates. We tend to go with a stakeholder route. There are lots of other important opinions we need, so we tend to try to solicit those as separate groups. So we haven't really thought of it as the advocate side or used specific advocacy organizations.
Great. You know, it's interesting. Many of us, when we're putting together a group, we have this kind of magic number in mind that maybe is 8 people on a committee, and many of us try to kind of balance approximately half patients and half other. Put on the spot, I'll ask you, an advocate, do you advocate as kind of, quote, taking a seat away from a patient if we bring them in, or do you consider them taking a seat away from another stakeholder, right? That, you know, how do you think through that if you were giving advice to somebody about building a panel of 8 to 10 stakeholders, and somebody raises the issue of maybe we should have an advocate? Do you know what I'm saying? Do you see them as truly being a proxy for the patient, or do you see them as, you know, maybe another stakeholder, and that maybe the reason we wouldn't go there is then we can't bring in a community provider or a community health worker or some other stakeholder? Any thoughts on that?
I think if I'm understanding your question correctly, we tend to lean towards patient. I mean, obviously, we give patients and caregivers as kind of the main bulk of our panels, and other stakeholders maybe less so. I guess so. The answer is, I guess yes. Those other advocate groups and those other stakeholders, there might be fewer of those. But I think that's really more because our question is really focused on what the patient's perspective is.
Yes, I think to get back to Ellen's point before about context, I think when we engage advocates is further in the research trajectory, right? So as we're beginning to learn, I think that we think that advocates probably have good insight into how to translate and disseminate information to patients, right? And so one of the things that we're working on, I wouldn't say that we have by any means solved this issue, is, you know, if we think about planning research and then doing research and then delivering solutions back to the community, it may be that the stakeholders change throughout that, you know, 2 or 3 year period. And, you know, we struggle with how do you bring a new stakeholder into a committee that already exists and make them feel part of that. But it may be that not only the individuals, but the type of stakeholder would differ at the beginning phases of research versus at the dissemination phase of research. And so I think that, I think that this is a dynamic process as well. It's not just a board that, always stays from the beginning to the end. Sometimes that board may have some turnover that's deliberate, not just because, somebody moved out of state and so you need to replace them. And I don't know, have any of you had experiences with, this is question number 3 now, the roles of patient representatives and whether those roles have changed as your research is going on, and then how have you, how have you kept patients involved as their roles change, or have some of you actually replaced some patient representatives with others as the role changes? And any of you who want to speak, just hit the talk button and like to hear some of your experiences with the roles that patient representatives have played in your studies and how that has changed over time. Ellen, do you want to comment on this? So you've done some studies that have gone on for a while, and obviously you've at some point had a patient have to leave, for any reason. So how have you dealt with that changing role or new patients coming into an existing group?
Yeah, I don't think it's been particularly challenging if you're somewhat sensitive to the idea that this person may not be as informed about the particular project as the others that have been there longer, and taking a little bit of time to get them oriented to make sure that the others that have been serving longer understand the role that the new person is going to play. I don't think when I hear there's problems, it's when people decide they want to put a patient on a committee that has not been very patient focused, and they sort of unleash them on the committee without any support or preparation for the patient or for the other professionals on the committee. Then I think it tends to not be a very positive experience. But I think some basic steps to make sure that they're well prepared go a long way.
This last question that we were going to throw out was really to ask about the different roles of patient versus family member or caregiver or advocate. But it seems like that, at least for those of you who have been willing to speak up, that it seems like that there seems to be consensus that many of us really like having actual patients with a condition who aren't advocates but are patients who are bringing their experience and experience of other patients they've interacted with. So rather than asking you that, because I think we've answered that question, what about what has been most valuable to you as researchers in the process of doing that? So I know for myself, one of the things that I've been able to do very successfully is help researchers who aren't that familiar with patient-centered outcomes research really work with patients to frame their research question in the voice of a patient. And at the University of Maryland, I think that many of our clinician researchers really now value bringing in patients, help them think about, how do we find the common ground and, the question framed from a patient voice. That, that seems to be something that people really enjoy. And I'm wondering, from the other sites, the other R24s, what have you found to be the most rewarding experiences, yourself or with your peers as you bring patients in as advisors and consultants into your PCOR studies? And I don't know if you can be. Go ahead.
So this is David Mayer again. So, I think maybe our most successful experience so far with this has been talking with patients with chronic pain in preparation, where we're preparing to start one of our projects in the fall on trying to improve primary care for patients with chronic pain. And really, the investigators on that project have found a fair amount of useful information, some of which they expected and some of which they didn't in terms of how patients understand their pain and the role it plays in their lives. So that's certainly influencing. They're considering modifying the intervention to take better account of what they're learning from the patients.
But it's always wonderful when you not only have that experience yourself, but kind of are able to share that with other researchers. Others on the call, anyone else want to share on this concept of what has been valuable to you in terms of bringing the patient perspective into a study, whether it's at the beginning stage or as you're doing it or at that final stage of dissemination and bringing what you've learned back? If not, what I'm going to do is I'm going to turn it back to Ellen. I really want to thank you again for coming and sharing with the other R24s today. And just, having heard some of the other discussions from some of the other groups, any final thoughts before we close out the webinar for today?
I think it's a sign of progress that we're even having this discussion. Even in the few short years I've been working in this area, I think we've come a long way from discussing whether to include patient representatives in research to what types of patient representatives are most valuable. And I personally obviously truly believe that there's experience and expertise that only patients and other representatives can offer to a project to improve the science and importantly to make sure that science is carried out in a way that is useful to those people at the other end. So I hope over time to see more examples, more evidence, more guidelines to help people figure this question out. But hopefully the things we've talked about today are a starting point.
It's funny, I laugh. I think back to one of the conversations we had with an investigator who was a little reluctant to go through this exercise. And at the end of the first meeting, which we had a series of meetings, but in the first meeting, and when we were done, he pulled me aside and said, wow, that question really is a better question of mine. And that was a very humbling experience for a researcher who had spent his entire career, a well-funded researcher, but new to PCOR, new to AHRQ and PCOR, and kind of more NIH traditional researcher, to really see that, wow, like within a 1-hour session, he really saw the value to himself because he also practices medicine on a daily basis. And so he sees patients and kind of to really be able to make that connection back to what he does when there's a patient sitting in front of him for care and to understand how if we did research differently, then that really would help him in his other role as a healthcare provider. So I agree with you. I want to thank everyone for joining today, and as always, thank AHRQ for funding the R24 series and for kind of helping to bring us together to do these webinars so that we can learn from each other. And look forward to next month, which I guess we'll be getting the updated information about Henry Ford's webinar for next month. Dr. Willis or Kwan, any final comments from you before we close out?
Hi, guys. This is Harry Kwan. I just wanted to thank you and Ellen for this wonderful presentation, and thank you for making this interactive. It was great to hear from the other R24 sites and just really engaging in this topic. So thank you very much for that, and I'll be sending out, again, information about our next webinar shortly.
And enjoy your afternoon.